afternoon, everyone. I'll be talking about management of strabismus in children with development delay. So who do these children comprise of? They are basically these children whose progression through the predictable development phase has either stopped, slowed, or reversed. And it involves either their cognitive skills, their social skills, their emotional skills, or it could be a combination of any of these. Common cause is obviously genetic abnormalities, but there may be environmental factors, certain medical conditions, or it could be a combination of these. And amongst the disorders which I have listed, it is the most common which we encounter as pediatric ophthalmologists is cases of cerebral palsy. Looking at the problems, these children have both sensory as well as motor problems. So amongst the sensory problems, they have a decreased fusion ability, and also the cortical visual impairment is pretty common in these children. While amongst the motor problems, strabismus is pretty high, along with the various other motor problems of fixation instability or impairment of the saccades and pursuits. So if you look at the prevalence in cases of autism and in the case of intellectual disability disorders is around 13 to 14%, and mostly it is the horizontal strabismus, which is usually infantile onset. But if you look at the patients with ADHDs, in these cases, there is a slightly significant increased risk of ADHD occurring in patients with strabismus. And again, here, as compared to the other cases where the esotropia is more common, it is the exodeviations which are more common in this group. While in learning disabilities, there's not much of a difference from a normal population, normal match controls, age match controls. Cerebral palsy, which is the largest group of children with developmental delay, which we see in our practice, the prevalence is as high as 90%. Here, both esotropia and exotropia are common, and as compared to a normal population who are not disabled, here the ratio of esotropia to exotropia is pretty high, of 2:1 as compared to 5:2 for normal population. So in cerebral palsy, let's talk about the deficits which are seen in cerebral palsy per se. So obviously the prevalence of primary non-fixation is pretty high, and there are anecdotal reports which say that the consecutive exotropia tends to occur spontaneously in this which suggests actually poor fusion. Because of this reduced or absent chiropsis, they may be having either intermittent or manifest strabismus. And in cases of milder forms of CP, there may be cases where children are non-strabismic, and in these cases also again there are some cases which have a greater chance of binocular fusion. And then I'll be making a note especially of this type of strabismus, which is seen characteristically and pathognomic of ethetoid CP, which is known as a dyskinetic strabismus, which is seen in almost up to 30% of cases. Its prevalence tends to increase with the severity of CP, and it is basically a concomitant horizontal strabismus, which has extreme variability every time we examine the child, which is unrelated to the direction of gaze or the fixation distance or any accommodative behavior or the visual attention. There is no periodicities, and this is associated with a very, very poor prognosis for vision, binocular single vision, and it has a tendency for exodrift over time. So the debate which we are faced when we are dealing with children is whether we should operate them or not. There are no golden rules to that. We have to assess what type of disability the child has, what is the severity of the developmental delay he has. We should not be pushed by the pusher expectations, because we have to see whether these expectations are realistic or not, because family is wanting every type of performance improvement in the form of intellectual, social, mental, cosmetic, everything. Teachers of these children are aiming for intellectual performance, but rehabilitation team is working towards the physical improvement of these children. So don't use evidence-biased medicine. Don't promise breakthroughs or miracles for these children. Don't make them emotionally charged. We have to be very, very realistic with these children. Think of the issues which are there. Why did it happen? Can we fix it? Is some fusion there? Because that will make our task easier, because that will help us in deciding whether we are just doing the cosmetic surgery or actually we are giving them some binocular single vision. So factors to consider, as for any other case of strabismus: what is the type of deviation? What is the binocular vision potential? What is the stability of the angle? And what is the compliance of the parents regarding the follow-up visits and the follow-up therapies? So issues which are specific to these are, obviously, we have very, very limited cooperation because of the communication, the comprehension skills of these children, and especially in the sensory examination part. So obviously, the data which we get is very, very limited in terms of its quantity as well as quality. And regarding the issues of anesthesia, I've always remembered that it has been seen in various studies that exposure to anesthesia before the age of 4 years itself in normal children is also associated with learning disabilities by about 50%, especially if the number of exposures is more than 3, or if the time of exposure per surgery is more than 2 hours. However, that should not deter us from not operating on these children, so we have to be especially taking more care to do smaller surgeries, faster surgeries in these cases, whenever we are proceeding ahead with surgeries. And another thing which is important to take care of in these children is basically, especially in countries like ours, they are in the vulnerable age group, so preschool age group, where if we can give whatever benefit we can give to them, obviously will have an impact on the neural development delay. So obviously we should try to align them to some extent. Even if you're not able to do surgeries, we can use Botox till puberty, and then maybe when we get better assessment, we can do surgeries in the cases where it is indicated. The limitations I've already listed below, before that, obviously difficulty in measurement, variability of measurement, unstable results, and compliance issues obviously will be against early surgery. So how to approach these children? Obviously, you have to have thorough involvement of the parents and the caretakers in this. Take them in your full confidence. Tell the parents that improvement in motor coordination after the surgery would be there for the child, improvement in visual perception would be there, and this will have a positive impact on his psychosocial development. But at the same time, inform the parents that there may be early as well as late misalignments or unsatisfactory alignments. So how to approach? As for any other strabismus case, first thing first is refractive error correction. Treat any underlying visual disorder. So for that, it is very, very important to do MRI on every such child. You have to do the MRI once. Aim for slight undercorrections in most of the cases. I'll talk about in the subsequent table, and use a multidisciplinary approach, because we're not just targeting the ocular aspect, we're looking at the other aspects also of the child. So besides this, also inform the educators and the teachers of the children, these children who are under special therapies. Give them the information regarding the visual field, the central visual field laws, the various type of visual aids which may work for them, especially the various conditions for lighting and contrast which may work for them. As regards to use of Botox in these children with CP, obviously we have started using Botox in infantile esotropias, especially the angles are very small. So how many times to be repeated in these cases? Who decides? There are not many studies or many literature available for, especially with for these children with developmental delays. But as for other cases of infantile esotropia, this can be tried in these cases as well. I don't have personal experience about that. But definitely no surgery when we are dealing with children with atheroid CP, diabetic CP, where Botox will work better, CP with small angles, where again Botox will work better, and a special group, as I told, MRI is must. So please remember, there may be patients who have homogeneous hemianopia associated with it, where exotropia is occurring to the side of hemiparesis with a face turn, and that is basically an adaptive behavior. So do not operate on this child. And again, no surgery if there is a low vision, there is a poor fixation, if there is an optic atrophy, or there is an associated CBI. Dosing of surgery, as I mentioned, obviously we cannot do with the normal standard doses. We have to do undercorrection, especially when we are dealing with the esotropic cases. For exotropia, we can still go with the standard doses, but not for esotropias. For esotropias, obviously, if I have to correct, if I'm dealing with an esotropia of more than 25 PDs, I would do an undercorrection of around 15 to 20%. And while for 20 to less than 20 PDs, if esotropia is there, then we can think of giving just Botox. For exotropia, you can do a bigger surgeries. So various responses vary according to the type of syndrome we have. For Downs, as I said, don't undercorrect, but for rest of the other cases, we have to undercorrect. And in developmental delay, so in the end, I will just summarize that obviously there's a higher prevalence of strabismus. The type of strabismus is almost the same as for normal children, although the prevalence is very high. And the binocular disorder which is occurring in these children is not occurring as a sequel to strabismus, but it is occurring as a sequel to strabismus, but not as a result of the development delay per se. So restoration of this binocular vision may be a realistic goal in some cases of children with CPs, and prognosis would improve if when the duration of misalignment is minimized, as for any other case of infantile esotropias. So, but especially for these children, what is more important, examining them multiple times before you take them to the operating room, do MRI imaging at least once, explain to the parents that the results are going to be less predictable, and which will depend on the specific type of delay which the child has. Younger the child when we are operating, more the chances that more the number of surgeries would be required. So careful consideration is what is required, especially when we are dealing with these children. Thank you.
Thank you, Dr. VINITA Gupta, for excellent presentation. Now I will request Dr. P.K. Pandey to comment, and any question from the audience also after that.
I think it was a very vast topic. Developmental delay is very broad. Even language
Yes, sir.
delay can be developmental delay. So
No, sir, that's why I lifted 4 or 5 disorders in the beginning. CP is the commonest group which we see in our practice, actually. CP.
impairment probably that could be more encompassing to what we were talking, because developmental delay becomes very broad, cognitive, language, and social, and those motor delay. So it's a very complex thing. And these children quite often may have an optic atrophy, will have refractive error, high astigmatism, and they also have poor motion vision possibility and poor hand-eye coordination. So
CP.
maybe cerebral visual impairment vis-a-vis what strabismus, I think would have been more to the point. And these are very challenging anyway, and they are very prone for, bit more prone for overcorrection. So while looking at surgical aspect, we should try to undercorrect by about say 1 millimeter or so. That would be better.
And
Actually, I was targeting only for CP. CP is the people which we, children which we see very commonly in our practice.
Yeah, but every CP may.
No, every CP we don't operate. We don't
cannot
operate.
have CP.
Yeah, yeah.
And you should also look at perimetral leukomelia saying these
This.
cases on MRI is very important because some of these may also look like glaucomatous cupping.
Hmm.
And I've seen some patients which have been diagnosed children as glaucoma, but actually what they had is they had cupping which was due to PVR and just looks like glaucomatous cupping. So that we have to keep in mind. In young children, don't diagnose them as glaucoma straight away. Consider these possibilities also.
thank you, Dr. Vinita. Another point, of course, to be mentioned is that not just surgery, but the follow-up of these patients,
Very
especially trying to get them rehabilitate the available functional vision in them. So we know that many of these children, which is being talked about, CVI, have a lot of field effects, particularly inferior field effects. They have accommodative lag, so they are having difficulty in near vision. So all these multifaceted interventions, including refractions and assessing the available field, we need to look at and manage. Thank you, Dr. Vinita, for highlighting this very, very important component that is now increasingly becoming something as pediatric ophthalmologists